Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. All right, everyone, welcome to another episode. Got some great content for you today. Thanks for tuning in, everyone. Today I'm with Dr. Vic Martel. He is a general dentist, an expert in many dental fields. He's practicing in Florida. Vic, thank you for joining us on the podcast.
Good to be back, Grant. Always fun.
Yeah, we've done a series now of several great episodes that I've gotten. Every time I have you on the podcast, I get great feedback and people text me, they call me, they email me how great it was. So really appreciate you taking time to do this.
Always.
Well, good. So today we want to talk a little bit about kind of malpractice and some of your experience and maybe some of the, I guess, advice and nuances there that you could help us out with. How, as far as your experience in being an expert witness in implant, restorative, extraction, and root canal malpractice, how did you get going with all this stuff?
Yeah, it's an interesting story. Probably it's been about 20 years, maybe 20 years ago. I actually had a partner back then, and he was getting sued for some silly thing that was, you relate to this. He was trying to take out a wisdom tooth, and he tried to elevate it, and it wouldn't come out. So he literally said, "That's enough. Let's send you to an oral surgeon." He called, made the appointment. Well, the patient never showed up to the oral surgeon's office, and he got infected. So he tried to sue my partner, and we'll talk about this in a few minutes. But even when you do nothing wrong, which in this case, the case got dropped eventually. But even when you don't do anything wrong, it's stressful. And what happened with me is the attorney was always in the office talking to my partner at the time and things like that. And we just had casual conversations after they were done meeting. And one day he just looks at me, he says, you sound like you have some interest in this. Would you be interested in ever, working as a defense malpractice legal expert? And I go, yeah, I'll try it. I said, listen, here's all I can tell you. I'll read the case. I'm just going to be as honest as I can be. And that's it. And I'll tell you whether it's a good case or whether maybe you should settle the case based on what I see. And he says, that's all I can ask. Yeah. So the first 10 years I did defense work like that. And then, as we'll probably talk about in a few minutes, it got to the point where there's some patients that were just being mistreated and things over time. So I was eventually asked, because once in a while you get an attorney meeting you or through, well, what happened in my case, which is a really crazy story. I think I've only been to trial over 20 years, maybe 3 times. Well, what happened was, in the second time I was on trial, the defense attorney, the plaintiff's attorney, was a dentist turned lawyer.
Oh, wow.
And it turned out, which is even more ironic, he was one of my prosthetic instructors in dental school, which is really crazy. And, he comes up and says hello, and I don't remember him at all, to be honest with you. And it turned out, fortunately, we won the case. And he comes to me afterwards and he says, listen, if you ever want to do any plaintiff work, let me know. And I said the same thing. I said, listen, I'm never going to do that on purpose. If you can send me a case, I'll look at it and I'll tell you whether it's something or not. And that's as much as I'm going to do. And he says, and I'm going to tell you the truth no matter what. That's what I said. And he goes, that's all I can ask for. And that's how all this started to roll. And, to give you a little background, maybe 20 years ago or so, I was probably reviewing, and like I said, first 10 years was all defense, but I was probably reviewing 6 cases a year, maybe. I'm doing 6, 7 cases a month now. It's got really, really, unfortunately, gotten very busy. And that's,
dang.
So it's had a lot of interesting turns.
What are some of the bigger myths or misconceptions about being an expert witness in a high-risk procedure?
I think the biggest, well, from a general dentist standpoint, and here's what I really want the general dentist to know, but it relates to specialists too. is, we're always taught at least that you're held to the standard of the specialty. And I'm talking about general dentists right now. And that is absolutely not true. And in fact, the way that, and I'm not sure about on a state by state level, but I know Florida, and it could be nationally, that if it's a general dentist getting sued by somebody, the expert has to be a general dentist. It can't be an oral surgeon. It can't be a specialty at all. For example, with you, Grant, if you're an oral surgeon in Florida, if something went wrong, God forbid, you could only have something with a oral surgeon as your expert. And so I think that's one of the biggest myths. And then the one that's the huge one is that it's never going to happen to you. It's always the really bad dentists that have problems. And I'm sorry, it's just not the case. It can happen to anybody at any time. And that's why what we're going to talk about today from a specialist standpoint or from a general dentist standpoint is so important, that you do as much as you can to prevent it. And that's the whole core, basis of this.
Okay, so maybe we could start with kind of the definition of the standard of care, because that term just has bounced around. And
Yeah, and
what is that?
That's so important. I actually wrote this down because and then I'll go into an explanation. So the standard of care is the level of skill, knowledge, and diligence that a reasonable, prudent dentist, which sounds very general, with similar training and experience would exercise under the same circumstances in a similar community. Well, that doesn't tell you much. Okay. In other words, now here's some additional stuff. The standard is it's not merely just what I just said, but it's based on peer-reviewed literature, all these other things. So it's not just what a dentist would do, but really what dentists that are following guidelines would do in the similar circumstances. Here's what I do know, and what everybody should know. There's no, stone tablets that came down from Mount Sinai that says dental standard of care anywhere. It doesn't exist. Okay. And that's what makes this so unsettling. And the reason is that everybody's opinion is different, right? Let me give you an example. I was in that same case I told you about that I was in trial. It was defending a dentist about a full mouth rehab. The details are not unimportant. But the lawyer on the other side, who I told you happened to be a dentist, says to me, Dr. Martel, do you think using a face bow during a full mouth reconstruction is a standard of care? And I said, no. And he looked at me kind of a little off, and he goes, well, do you use a face bow when you do a full mouth reconstruction? I go, yes, I do. But that doesn't make it standard of care. Okay.
Okay.
So that's where these little subtleties come in, where it's something that certain things, a good example, is a rubber dam during an endodontic procedure a standard of care? Yes. Okay. That's actually written in the endo literature. Okay. Things like that. And in your case, and I talk about this during one of my lectures, one of the other few things that are standard of care all over the country, I'm pretty sure, is when you're going to edentulate a patient on a lower mandible, and you're going to, maybe you're going to do immediate denture. The standard of care today is to always offer them at minimum 2 implants and locators. That's a standard of care. That doesn't mean they have to accept it. It just means you have to offer it.
Got it.
So there's certain things, and those are about the only 2 that I know that are literally written down. Everything else is, and that's what makes it difficult for this and stressful for the dentist and even the specialist is you might be doing something, Grant, and there might be an oral surgeon in Miami that you might know that says, no, that's not the standard of care. It's a matter of opinion because they do it differently than you. You have to be very careful on what you would call standard of care for dentists, because it's not the same. And believe it or not, that definition I read you might be different in Colorado than it is in Florida.
Okay.
Thing.
Yeah, and it's interesting to think about what actually potentially shapes, the standard of care, and where do we get that from? Because of course, we think probably a lot of it just comes from like the white papers and like research. But I mean, have you ever felt like you were shaping the standard of care?
Probably not necessarily shaping it. I wouldn't say that at all. I would say that because I've been doing this 20 years, I probably am much more aware of what standard of cares are. I mean, let's put it this way. A real simple one. It's not even the procedure. Should the standard of care, and we'll talk about this in a few minutes, to keep really good clinical notes, yeah, that should be a standard of care because that's where most dentists falter. That's where most dentists can lose a case. You could be an excellent dentist, you could be an excellent surgeon, and if you're, and I can tell you this through experience because I've dealt with it hundreds of times. If your clinical notes and things are horrible, you're going to lose. I'm sorry, you're just going to lose. And the reason, one of the interesting things that most dentists don't know and specialists is, Grant, if God forbid, if you were getting sued, you are never allowed to speak to the expert that's defending you. Okay. So what do I mean by that? I can read your clinical notes. I can read your deposition. I'm never allowed to speak to you. So those clinical notes become critical.
Yeah.
Okay.
Wow.
Your deposition helps, but I'm looking at your notes, and if you're, we've gone in a whole different direction now with digital notes and things like that. So, but we'll, go ahead. I'm sorry, I interrupted. I went off on another tangent, but you go ahead and I'm sure we'll get to the notes in a second.
Yeah, that's what I kind of want to talk about next. As far as maybe your experience with, I'm sure you've read so many chart entries and seen different ways of taking notes. And, has any of this changed how you document your procedures?
Yeah. I mean, probably, after maybe the first year or two of defending dentists, I went extreme. I mean, I literally had my assistants, as I'm speaking, writing. I mean, everything. Okay. And then I would, when the patient left, at the end of the day, I would review the notes. I would edit them. I would add anything I needed to add, because that's everything. And you know what? One of the things I tell dentists and specialists, because it really doesn't matter at this point, is you should be writing your clinical notes as if I'm going to read them. Meaning, yes. Okay, somehow Grant just got a subpoena, and now I'm reading your notes. But every patient's notes, every doctor's notes should be as if you're going to get sued and I'm going to read them. That's how detailed they are. And the challenge that we're dealing with now is this, and you deal with it every time. I had a big transition. I'm sure you won't appreciate this because you're too young. I had a big transition where I had to transition from writing charts out to digital, right? Because everything's on computers nowadays. Well, the problem with that is dentists become, and I'm not sure, I mean, you can tell me, Graham, for specialists, dentists have gotten too comfortable with templates. Mm. And the problem with a template is it's not detailed enough. And some dentists, and I get it, if you're in the kind of practice where the general dentist or the person is seeing, 20 patients in a day and you're busy and you just want to hop from chair to chair, writing notes is drudgery, or, even on the computer.
Sure.
We've gotten to this tendency in the templating world of digital computer charts is that, nothing's ever going to happen. Let me just use their little templates, and you don't put in enough detail. So you're forgetting that I have to read them. And that's where the ball gets dropped, because I can, even if I think the dentist may have done something wrong, if your notes are clear as day, I can defend you all day long. If, on the other hand, I don't think you did anything wrong and your notes are horrible, we're going to have a challenge, because it's all a matter. I mean, I'm just reviewing a case yesterday afternoon, and the treatment planning notes were horrible. There's nothing in it about reviewing history and all those things. And I'm talking to the attorney. I go, yeah, I'm sure there's nothing going on here, but the notes are just horrible. And I don't know what you can do about that, because obviously you can't change notes, right? Because that's illegal. And it becomes a problem, because you got to remember something. If it never does. To give you an example, probably 2 to 5% of cases end up at the trial. Very, very, very few.
Right.
But if it does, don't forget, you're sitting in front of 8 to 12 people that know nothing about dentistry. This jury of your peers, it doesn't exist here, right? Because they're not 12 dentists sitting in the jury box. It's 12 lay people.
Yeah.
They don't understand it, and they're trying to, get their way through this information, and it's very, very difficult. So they make decisions. You got to remember something. They're going to make decisions whether it's true or not. Part of it's going to be emotional decisions, right? Part of it's going to be what their gut tells them, as opposed to here's the evidence, here's what happened. And even if I'm up there, I had one case, one of those few that I was at trial, I think the third one of the last one many years ago, I was on the stand for 5.5 hours.
Wow.
Yeah.
Jeez.
And personally, the dentist didn't do anything wrong. But the plaintiff attorney just grilled me for 5.5 hours. It was brutal. This is the irony. It was over a 3-unit bridge.
Oh my goodness. Okay.
So this is how extreme it can be. And the dentist had very poor notes, and one thing led to another, and that's what happens. So it's I think the two things mostly is, number one, never think it can't happen to you. It can. And number two, write your notes like it's a diary. And this is where things change, because, we'll bring this up in a second, which is informed consent and how all that works.
Well, yeah, this point about note taking is, I think, worth focusing on. Like you mentioned, I think most of us did not get into this profession to be documentarians and to write things. We got in this profession to do stuff, right? Especially surgeons. And so it's pretty painful to know every little thing that happened. And so that's why we're constantly trying to think of ways to make that process less painful. And of course, now we've got a lot of AI tools and digital tools and all sorts of good stuff that could help us. But as far as what you've seen in the notes, here's my general take. I feel like we do a better job documenting the procedure and like all the things we did, because that's the exciting part, and not a great part with the diagnosis and everything that went into reviewing and their health and the reasons we got to where we needed to do the surgery and why we're doing the surgery. Would you agree with that, or where do you see most of the errors in note taking?
100%. And here's the challenge. The average surgeon or general dentist, no matter who it is, you're under this, and I'm going to use the word delusion, that your templated informed consent is good enough. I can tell you this: when I'm reviewing a chart, the first thing I do is I take the informed consent and I put it off to the side. Here's the reason. I don't know if they understood what was on the informed consent, even though their signature's on it. I don't know if you explained it well in layman's terms. I don't know if they were so nervous they didn't hear what you said. All those kinds of things become a challenge. And the other side of it is, and it's going to sound tedious, and I'm sorry, but this is to keep you and everybody else out of I don't want to use to trouble, but out of litigation, is this. Your notes should be at this level. Explain this to patient. Patient said this. Gave them the alternatives. Gave them the benefits and the problems with each one of those things. Patient understands. Those are good notes, okay? And even when patient says something, it should be in quotes. Patient stated this, right? And I think today, and you might be much more enlightened in this than I was near the, when I was working full time, is, are there any softwares now, Grant, that can, as long as you get permission, you can audio record and it gives you notes of that conversation that you can keep in the chart? Because that would be the ideal way. That would be the least painful way, right? For example, I don't know if I ever told you this. There's this little device you can buy on Amazon. It's called a Plaud, Plaud. It's about the size of a credit card, thickness and size. In fact, it's probably exactly that size. It's an audio recorder. But the beauty of it is it does this. Number one, you ask the permission of to get, the person. In some states, it's both ways. In some states, you just need, in Florida, you have to get permission and they have to say yes. But the beauty of it is you record the conversation and then you go in the app and it gives you an exact transcript of the conversation.
Oh, nice.
And not only does that, if you wanted to, it summarizes the conversation. It gives you bullet points of the conversation. So I've actually had some surgeons that I work with during my programs when I'm lecturing, they actually record the whole program and I don't mind. And so now they have transcripts of my lecture that they, email out to all the attendees. The same thing can be done. I'm sure it's gotten much better than that. And maybe you know more about it than I do, where if you get permission, I think that's the least painful way would be, because you talk about something that's thorough, right? It's an exact transcript. It's a bullet points, it's a summary, and that would be in the chart. And boy, it certainly would make somebody like me's life easier when I'm trying to defend you. And still today, there's plenty of people out there that are still writing charts. And unfortunately, if you're like every other professional, your handwriting is horrible, right? And it looks like chicken scratching, and I can't read it even if you gave them had good notes. So it becomes a challenge. And you know what? To give you a little reasoning, I think one of the reasons that we're seeing more and more litigation, and I'm reviewing more cases, is the amounts of money for cases are gone way, way up. Okay.
Interesting.
The word, from the data bank, the dental data bank, we just had one this year, I think it is, in Texas, where a child passed away from, doing a patient dentist was doing a filling, passed away during sedation, $95 million.
Wow.
Yeah. 95 million.
Gosh.
So,
Wow.
And that's way beyond. I mean, there's other ones. I think there's one in 2025 in Florida that was 4.75 million. There's another one that's 3.75 million. The 4.75 was just a full mouth reconstruction that went bad. The patient, poor margins, whatever it happened to be. So that gets the attorney's attention, right?
Yeah.
Where, for many, many years when I was defending dentists, it was like, okay, maybe an $80,000 case and things like that. And even though that sounds like a lot of money, the stress involved for the dentist is way high, because what you may not know is from the day of a subpoena until the settlement, let's say it settles, 1 to 2 years.
Wow.
So you're living with that stress for 1 to 2 years. Having said that, if it goes to court, 5 years average.
Oh my goodness.
So, and I have one out now that I'm defending the dentist. It's been 7 years. That stress for the specialist or the dentist is just something that you just don't want to deal with. So avoidance is obviously the best way, and great notes. But
okay, maybe we could talk a little bit kind of about some of the trends. Do you know any of the stats as far as
what we're seeing? Some of the stats are it could be Florida based, so forgive me, but what we're seeing now and what I'm seeing, and I mean what I'm seeing anecdotally. Let's go there first, because these are the cases. I do have some stats, but let's go anecdotally at what I see. I would say that probably the number one cases that I see that are significant amounts of money are nerve injuries. It's just, you have to remember that there's a lot of general dentists, and I can only speak for that because that's me, right? Are doing some procedures and injuring nerves, and and especially if it's something that is permanent. Permanent nerve injury is a big problem. Okay, I've probably seen at least 20, 30 cases, reviewed at least 20, 30 cases with just nerve injuries. Okay. You'd appreciate this one, and this is I tell my oral surgeons this when I'm meeting with dinner with them. I don't like to talk about this during our courses, but there was a dentist years ago that I was reviewing the case and taking out a lower wisdom tooth and cracked the mandible in half. That's a problem, right?
Mm-hmm.
I had another one that was taking a simple number 30 out, not even a wisdom tooth. And unfortunately, the dentist, in this case, actually wrote notes too detailed. She said, the dentist says, well, there's a lot of decay and it's through the furcation. So I just grabbed a pair of this is literally what she wrote in her chart. I'll just grab a set of cow horns and put all my force on it. This is what, instead of,
Oh boy.
And again, cracked the mandible in half. Well, the mandible had to be set, ended up getting an infection, had to go up to University of Florida, lost the inferior alveolar nerve. And I called the attorney up and I said, settle the case. Just settle it. You're going to lose.
Yeah.
They ended up settling the case. So that's a biggie. Endo, overfills, especially lower overfills, because if you're doing a lower overfill in the back molar and that overfill goes into the inferior alveolar canal, big problem. Okay. And then again, at that level, I mean, if I was on the plaintiff side of that, the first thing I would do is I'd go, did they use a rubber dam? And if there's nothing about it in the notes, I would say settle the case. It's over, because they just deviated from the standard of care. So it's that. And then actually, and it's unfortunate, but it makes a lot of sense. Probably a lot of the cases are implant cases now. And it's a big deal because there's more and more people doing implant procedures for, I guess it's a highly profitable thing. I was never on the side of doing implant surgeries. I didn't enjoy it, so I never did it. But the challenge is there's so many things that can or might go wrong that, we're dealing with cases, where, to give you the perfect example, there's so many, and you'd appreciate this, there's all these all-on cases happening all over the country, like all on 4, all on X, whatever you want to call them. And, it's probably rare when they go bad, but when they go bad, they go really bad. And the problem with that is you lose all the bone.
Yeah.
Now let's talk about a maxillary. You're doing a maxillary all-on case. Implants, I looked at a case where the implants weren't even in the mouth for 3 or 4 months. They hadn't even been still in the provisional. All the bone goes away. At the level where the only way to fix this person would have been to do, heroic grafts or zygomas and pterygoids.
Okay.
This was over a 3-month period of time. Okay. So implants, nerve injuries from extractions, endo are probably the big 3. Certainly there's cases to be said for, and I'm reviewing one, trying to defend one right now where it's just crown and bridge and lots of open margins and things like that. Those happen. They happen probably farther, between than all these other ones, because I think the most common ones now are the implant cases and the nerve damage ones. I think those are where really we're seeing a huge spike in these things. So it's unfortunate, but that's part of life.
What's the biggest CBCT, red flag finding that you've seen in cases where there's an implant or a lower molar and it doesn't turn out well?
Yeah, well, and that brings you to the point where, and I get to ask this question all the time. If you're doing implants, you're doing wisdom teeth, and it sounds I was asked it probably more frequently 5 years ago than I am now. But one of the questions I would get asked is a CBCT standard of care? Mm-hmm. And I said, no, unless you get in trouble. Right? Unless something happens, you're probably okay. Right? Today, I'd probably say yes, but think about this, Grant, and you see this every day. Look at the lingual plate, and all of a sudden you're putting an implant in, you perf the lingual plate on the lower, and it's like, if you have a CBCT and you perf the lingual plate, that's a problem
Yeah.
because you should know where you're going, right?
Mhm.
I guess if you didn't have a CBCT, I'd go, well, maybe you didn't see it three-dimensionally, but I still couldn't defend it, right? Because now I'd say you should have had a CBCT. But
Right.
now knowing it actually puts you more on the spot because now you should have been able to avoid it by really being able to read the CBCT at a level of 3 dimensions and things like that. So it can be a challenge now. So, dentists become very cavalier, maybe, because they do a lot of cases and nothing happens. One of the things I tell people is, and now I could say this to a specialist, even though I wouldn't defend you because I'm not an oral surgeon. I say, listen, this is what I say to general dentists sometimes. You're doing, let me give you an example of a wisdom tooth, right? They take a wisdom tooth out. Let's say it's a lower wisdom tooth. And I tell them, listen, the $1,000, the $500 you're going to make off taking that wisdom tooth out, if you get sued over that, you would gladly pay me $50,000 to make that case go away. Now, obviously, I can't charge them. I'm just giving them their thinking process of how stressful this is going to be for you. So
Yeah.
if you're looking at a case and you're hesitating, probably a good idea to refer it. And we've talked about this in other topics. I'm a big interdisciplinary guy. I'm more like the triage guy. You need a wisdom teeth, go see Grant. You need this, go see this person. You need a root canal, go see this person. And I just did what I did and tried to do what I do really well and stuck to my circle of influence of what I could do and I knew I was capable of. And that becomes the challenge. And this is where I sometimes I sound like I'm preaching to dentists is I say, if you can't handle the complication of the problem, you probably shouldn't be doing the procedure.
Right.
And that's where people get a little brave or cavalier because something doesn't happen the first year or two, and now all of a sudden something happens, and it's a big deal. All you need to do is go through one case legally, and you're well. I'll give you an example. That one that I just told you about that cracked the mandible in half,
Yeah.
gave up their license, just left dentistry. It was so stressed.
Wow.
They were only in their 20s.
Oh my goodness.
So it can be very stressful. And I feel for them because, if I can't defend you, this like, I'm sorry. It's just, there's too much here that I know you're going to lose. So,
Good grief. Maybe you could just talk about s- like the main missing parts of a consent or a note. Like for example, with lower molar extractions, what's the number one missing sentence that you kind of wish was there, but it's not there?
oh gosh, there's probably too many in the sense of what we're thinking. But let me give you an example. Dentist takes a lower molar out and the person comes back with some numbness. Okay. I think the dentist shouldn't say, numb, check them later, just being making notes about it. It should be, patients complaining of temporary paresthesia. Let's check them in a week. If it doesn't look better in a week, let's refer them out to an oral surgeon. In other words, immediacy. Many, many cases that I read is the biggest challenge that the dentist had is they failed to refer soon
Yeah,
enough. Okay. In other words,
got
if a patient's complaining of a numb lip for 4 months and you keep on saying it's just going to go away, it'll get better. It'll get better. That's the kiss of death. What you really want to say is, let's check it in a couple of weeks, and if it's not get better, let's send you to Dr. Stucki or whoever, because that's where it means. And if you're diligent about it, I can defend you all day long because you did what you should do. And that adage of I'm cleaning it up, things happen. It does. Things happen to everybody. It's how you handle the problem is what separates people, right? If
yeah.
I send it to you the next 2 weeks later, I can say he did everything right. Stuff happens. So that's the most important part of that, I think.
Um, how about your 30-second soap note for a post-extraction numbness complaint? I mean, any
Yeah, I
tips
think
on that?
I don't. Well, I'm sure you do this because of your training. Dentists don't, and even though all of us were taught in dental school to use soap, right? Subjective, and
Yeah.
very few, and I can tell you this, I've read hundreds of charts, never seen it, maybe once or twice. So
Okay.
just left out most of that's the biggest problem is it's left out. And the challenge with that is it's so simple because it guides you through the process of diagnosis, assessment, all those kinds of and plan. But it just very rarely, and I think we just get busy in our own little lives. And I'll be honest with you, years ago I was guilty of it too until I started reviewing cases, and then I went right back to it again because it makes your clinical notes so clear and precise. Let me give an example, like endo, right? Did you run the hot and cold test, the electrical test? What was your diagnosis? And because what you're really looking for is what was the reason you did the root canal? Okay. Now, I don't have the specifics on this case, but literally, this is the case I was reviewing yesterday. Patient goes in, emergency patient at a dental office, on an emergency plan. It wasn't even the patient's dental office because she was on the road. She walks in because she's having a severe toothache. They treat her, they see her, they tell her it's one tooth. They pull the tooth and put an implant in. She's still in pain. In that same visit, they realize it's the tooth behind it. They ended up doing a root canal on that tooth. Okay.
Yes.
Now, the patient lost a tooth for no reason. That's a problem because I don't have, and the notes are horrible. I don't have the soap notes. I don't have a diagnosis. I don't have anything. So this is going to be one of the ones I'm going to say you probably should settle the case because it's not looking good. So.
Yeah, that is really interesting. I mean, I get referrals. Like just the other day, I got a referral for extraction or evaluation of a lesion, and possible biopsy. And then I'm looking, and there's big radiolucency on number 30. I'm probing. There's like pus in the sulcus. I mean, and I'm testing it, and everything looks like this tooth number 30 is cracked and is infected. But the dentist thought the tooth 30 was totally fine, and they told the patient that they probably had a growth in their jaw and they could potentially have cancer. It's just so wild how diagnosis can be so different between providers, and how critical it is to document all the details. And how did you get to that diagnosis? What did you do to get there?
Exactly. Yeah. I mean, just saying somebody needs a root canal and then start doing, and as you know this as well as I do, what I did say, and this is where the problem is of this case I was just talking about from yesterday, is all you have to do is send me the x-rays. I'm going to be able to tell you in 10 seconds whether or not he pulled the wrong tooth or not. Because if he pulled the tooth and it looked like a perfectly healthy tooth, well, guess what they sent me? The x-ray of when the tooth's already gone.
Oh, gosh.
And I learned this one statement many years ago from John Coyce, which is, to me, it stuck with me so well. A patient will always pay you more for what you know than what you do. Diagnosis is everything, right? Even if I diagnose and I refer it to you, at least the patient was taken care of in a precise and organized manner, we've talked about this in a lot of in the other program sessions we've done, but this, when it comes to malpractice, is super important. And I say this a million times. There's a lot to be said for shared liability. Okay, meaning if I don't know what's going on with this patient, let's send it to Grant. Let's get a biopsy of the lesion. Those are the kind of things, at least. And I understand. Maybe I do. Maybe I don't. That a lot of dentists want to keep everything in house. I've just never been that. I'd rather have that patient go see the person that is going to give them a definitive diagnosis and things, because maybe that's not within my realm of knowledge. And at least I know the patient's taken care of, as opposed to, let me just do it all because I want to make an extra $1,000 that day or whatever it happens to be. And you know what, maybe for some dentists it works, but for me, it's never worked. I didn't enjoy it doing things that way. So it became, and thank God, 38 years of full-time practice, then part-time after that. I've never even had a threat of a litigation case. But maybe it's because I was referring everything to everybody else and only did what I did. But that worked for me, you know. And unfortunately, the dentists nowadays, and you know, we've talked about this in different ways, they because of their school debt and things like that, they tend to do more procedures in-house. And I think that's why we're seeing lawsuits, litigation go up, because we're seeing this. Let me do this. Let me take the wisdom teeth out. Let me do the biopsies. Let me do everything myself and keep the money in because I got to pay these expenses. And you know, fortunately, things don't happen that often, but when they do, it's very stressful. So
For sure. You know, and there's so much stuff like you're hinting to that we should communicate to the patient um, as far as informed consent. Is there anything that you or your staff should not say that you do see that is said, like after a root canal or an extraction procedure? Is there any recommendations there?
I think the only thing that we kind of alluded to it before. Number one, this is a joke, but it's not a joke. Never say "oops." That's a whole other topic, right? Don't.
Right.
And yet, you know, I think you referred to this when you were talking to, I think it was your brother a couple podcasts ago, and your patients are sedated. So even those conversations, you know, you're a little bit more careful in front of a patient. Dentists and, you know, general dentists, our patients aren't sedated. So what you say is super important, right? But also is it'll get better. It'll get better. Just, you know, you'll be fine. And that's not something that you should be handling. You should be at minimum, let's say, let's check it in a week. If it doesn't get better, let's move on and send you for here. Never just kind of, you know, put it off on a shelf and just assume everything's going to be fine. What's the worst that could happen? I send it to you or whoever, and between the two of us, we decide it's going to be fine. Okay, now we have verification. Now we have, you know, the patient's been assured. And many times, as you know, lip numbness comes back, right? You know, it takes sometimes up to 6 months or whatever it happens to be. But that stuff, permanent nerve injuries happen. But I'm not the one to judge that, right? I should be if I'm doing something like that, because that would be a complication. But many times it's not in certain offices. So I just never wanted to deal with those types of complications. So that's why my office was more of a triage. But what you say to a patient, because trust me, if you have a conversation with a patient, the only thing they're going to remember is all the bad things.
Yes.
It's just the way human nature is. And well, he told me this or he told me that. And, you know, and granted, when I'm defending you, I know I'm not, you know, intelligent enough to go, well, that's an emotional conversation that probably has nothing to do with the facts, right? And ultimately, we take that away. But here's another one. When you go back to the informed consent thing, never assume they understand what they signed.
For sure, yeah.
Okay, and that's why, to me, as an expert to general dentist, I honestly don't care if the patient's signature is on there. I don't know if you discussed it. I don't know if you explained everything. I don't know anything about that. Now, on the other hand, if you had it in your chart that explained to patient about this, they said this, explained this, and that's different, because that now I know it's a conversation as opposed to just handing somebody a piece of paper and they put their signature on it. Now think about this. You deal with this all the time. What if you're handing somebody a piece of paper and they're in so much pain they just sign it and they're not listening to you, they can't hear you?
Right.
In fact, I would tell dentists all the time, let's say they're coming in for a toothache and you don't know if you're going to do an extraction or a root canal at that point. There's nothing wrong with getting the patient numb, making them feel better, and then giving them the informed consent so that they can rationally think and they're calmer and they're not so emotionally and hurting. And what's the worst they can do? You know, they decide they don't want to do anything. You go home, your lips, you're numb for a couple hours, but you made a rational decision and you explained it well. The worst thing a patient can do is sign a form when they're not thinking straight, because that's why those things carry such little weight. And in my mind, they do, because I can't verify what happened that day from it.
Yeah. Could you talk to us just a little bit about defense strategies and risk mitigation? Things that, once there is a suit or some potential suit going on, where do you help people go with this and how do you recover if possible?
Yeah, I mean, the biggest error I see that's easily avoidable is once this thing, well, number one, this is even before the one I was just going to say. If a patient calls your office and even threatens a lawsuit, you need to call your insurance company immediately. Most dentists don't want to do that because maybe they're embarrassed or whatever it happens to be. Okay. You have to. It's so important to at least inform and get somebody ready to defend you. That's one. Number two, and I know this one's a hard one. You can't talk to anybody about the case. You can't. I don't care if it's your staff members, your best friend who happens to be a dentist. You have to just, and this is the hard part because it's so emotionally stressful for you. You want to vent, right? You want to just
Yeah.
get frustrations out, and it's a challenge. Here's to put people's mind at ease, and this is where it goes back to prevention again. If your notes are great, you probably can relax because nobody's getting sued. I can't say that because there's a lot of frivolous ones out there too. But for the most part, but those ones you'll win. Nobody's getting sued for just a complication, right? Because complications happen.
Right.
Now, let's give an example. Let's say you did an endo and it never healed and it looks decent and the tooth needed to come out. That's a complication. Okay. You have good notes. We're good. Okay. Mm-hmm. Pulling the wrong tooth, that's not a complication. Okay. That's a problem. All right. Because, and let's go a little bit further. And I'm sure you do this every time is you're taking out number 12. Okay. You literally show the patient number 12. You have them put your finger on it. You show them in a mirror. This is what we're doing. Correct, Mrs. Jones? And you're okay with this. And that needs to be clinical in your clinical notes. Verification, no different than now hospitals, if God forbid you're amputating a leg, they put a big Sharpie on the leg that they're amputating, right? It's the same thing. And we get, you get so busy in your practice in your procedural life that you tend to just not be really cognizant of taking care of that kind of situation. And all you have to be is wrong once and it's stressful, right? So the best is, and on the other hand, I had a case in Oregon, believe it or not, that they called me up. A guy did a full mouth crown and bridge, upper and lower. The patient was suing him because the bite was off. It was kind of a silly case. These dentist notes was so meticulous. His photography, he mounted models, he took pictures of his mouth. This is before he thought anything would be, it's just who he was.
Yeah.
And I said to the attorney, I said, this guy didn't do anything wrong. I wouldn't have kept that good of records on the case. And I do this all the time. Well, it turns out they dropped the case because it was, it was so easily defendable. And on the other hand, it could have been the same case and his notes were horrible and he probably would have lost.
Mm.
I get it, and surgeons are different because you're in there, you're in the blood and guts and you just want to get to the procedure and move on. And ultimately also, and it doesn't have to be you writing your notes, but you should review your notes and make any edits and things like that, and I know that's tedious. That's where maybe some of these, and I think there's some, maybe your viewers can look them up and they might already know this. I think there's some softwares out there now where it integrates with, what's the software you have for your office? OMS?
Well, we use Epic. It's like a medical charting, but it's a huge thing used through a lot of hospital systems now.
Okay. But there must be some type of recording thing where you can transcribe notes, or I think there is. I don't know about yours, but that's the best thing because the entire conversation is recorded. Now, granted, you and your team need to be cognizant it's being recorded as well, right? But
Yeah.
bottom line is records are everything.
Yep.
If I were going to give any dentist, whether it's a surgeon or not, granted, you wouldn't jump in and do a crown on somebody, right? Because you're not qualified to do that anymore. It's not something you do anymore, right? But ultimately, the good and the bad of what I do as a general dentist is I'm allowed legally to do anything in dentistry. That sounds good, but it could be a curse, right?
Yeah. Yeah.
Because you're not, doesn't mean just because you can doesn't mean you should. And ultimately, that's where things get hairy. And for you as a specialist, and this is going to be important for all of um, your listeners that are oral surgeons, is you guys have a tendency, and it's a good thing, to bail people out, right?
Mhm.
They send you over your complications. But here's what I want you to know. If that person ever gets sued, the previous dentist, your notes need to be meticulous because
Yeah.
they're gonna ask for your notes.
Yep.
I've read many oral surgery notes because the case ended up going over to oral surgery after the GP, something happened, an incident happened there. And I have to read it. It doesn't mean I'm holding you accountable, but what I'm saying is they have to be meticulous because ultimately, even what you wrote is going to be brought up.
Yeah.
It can either benefit the general dentist or not.
Yep. My couple comments on notes. One is um, phone notes because I get a lot of texts from patients, calls from patients, and oftentimes it's hard to remember or to stop and say, okay, let me document that in the chart. But like, I think it's important to leave a paper trail of what happened there. Like just yesterday, for example, we did a large case. We were going to prescribe some stronger, Percocet type pain pills for the patient. The wife said, "Oh no, I think he's allergic. Let's not do that." Okay, so we did something, milder. And then after the case, the patient calls and says, "I'd like Percocet because the pain's so high." Well, I thought your wife said you were allergic to that. Well, I mean, here's what was my reaction was I'd really like to try it again. I was just more nauseous. And so I jump on the chart and pop that in real quick just to leave some type of trail. Hey, there was a conversation, there was a discussion. Here's why we did this. Here's what the wife said. Here's what he said. And it's kind of annoying to do all that, but if anything went south, a patient had an allergic reaction, I want someone to know what I was thinking and why we made those decisions and who I talked with. Would you agree
Absolutely.
with that?
100%. And here's the other challenge that we're dealing with now because of technology is is everything we're doing, meaning text, are you on a HIPAA compliant text,
Right.
right? And that's where, not for a plug, that's where Tom Stone's doctor talk is valuable. Everything is in there is all HIPAA compliant because, we tend to text like it's no big deal, right? I text you about a patient and things like that. And hey, Grant, can you see Mrs. So-and-so? If it's just a normal text, it's not HIPAA compliant. So we have to be very cognizant of that. But you're absolutely right. Phone conversations, because I'll give you the perfect example. I've had many, many cases that I've reviewed. Guess what I get copies of? All the texts.
Hmm.
Because there's a very easy way for an attorney to go to AT&T or whatever and get copies of the text. Just because
Right.
you delete it doesn't mean it's gone.
Yeah.
And granted, they're kind of tedious to read, but they're going to accumulate as much information as they can about that incident, and it's therefore what you did is exactly what you should do because you're absolutely right. It's like why would I? If let's say you had a partner, Grant, and you called in antibiotics for somebody because he was happened to be on vacation, and you didn't bother to check whether they were allergic to penicillin or not. Now we got a problem,
Yep.
right? So those are the sorts of things where they seem so casual, but it can end up with a problem.
Yeah. Good point. What's your final kind of 10-second warning or thoughts on this topic for those who are trying to avoid problems, either a dentist or a surgeon?
Yeah, I think two things. Number one, and I've said this a million times. I feel like I'm beating a dead horse, but it's never do a procedure that you can't handle a complication. That's number one. Number two, it's kind of like real estate, location. Document, document, document. The most important part of a legal case is documentation. I was just in a deposition about 3 4 months ago. I was in the deposition for 5 hours, and it's because the notes were so horrible, and we're trying to work through them and what this has happened and what didn't happen, and things like that. So that could have been an hour deposition, but because of the messiness of it and the unorganized atmosphere of, situation, it ended up turning something that, and I'll be honest with you, I'm not sure that the case is going to get won. I think the case might have to get settled, but that happens. So documentation is everything. Informed consent should be verbal and customized, not templated.
Yep.
And clinical notes should be customized and not templated. If you do those things, it's very easy to defend somebody. If you don't, even when you don't do anything wrong, it's very difficult.
Well, that's really good to hear. I mean, I think a lot of this applies to what we're doing in surgery. It's a good reminder, just for our guests. We've done multiple episodes on note taking. We've talked to attorneys. I've done multiple episodes on how to avoid taking out the wrong tooth. I mean, so much stuff we're trying to pass on to others about how to avoid this. Because, like you're saying, even if it ends up that you win the case, quote unquote, you lost so much time of stress and sleep, and we just don't want to get into that situation. So it's worth it to take these small steps to avoid it.
Avoidance is everything, and ultimately, so let me leave you with this too. Because I deal with some plaintiff work over the years, and it's probably now 60-70% defense and 30-40% plaintiff work. But I can tell you what happens, and this will probably put your mind at ease. The attorneys on the plaintiff side normally would call me up and say, "Hey, Dr. Martel, what do you think about this case?" Meaning, here's what happened, blah, blah, blah. And 9 times out of 10, if the documentation is good and it doesn't, and it might be just one of those things, complications happen, I'm going to say to the person, the attorney, this is not a case worth pursuing. Drop the case. Mm-hmm. And they appreciate it. And the reason is they don't want to go to the expense of going through all the depositions, because, what people don't realize is the plaintiff attorneys put out all the money first, right? And then hopefully they win. And in their case, hopefully they win. And ultimately, that's how they make their income. But when I tell them that, they go, here's what they say: "Thank you. We're good." Because they're not the ones to judge those cases. You are, and I would be. Just like if somebody called you about another oral surgeon, Grant, and they ran a complication by you, you could easily say, "Well, it's a normal complication, and he documented it fine. There's nothing here." So many, many times, probably the majority of the time, I get a call from a plaintiff attorney. I'll say, "Listen, the guy didn't do anything wrong. His notes are good. Just forget it. Let it, don't even take the case, because it's not worth it." And that's really valuable, because dentists don't understand that a lot of times experts from the plaintiff side, I'm going to tell you to not take the case unless it's really something blatant. And I think the patient was harmed from just, supervised neglect or whatever it happens to be.
So document, and work within your scope.
That's the perfect way of putting it. Work within your scope. Absolutely. Yeah.
Love it.
I'm sure there's things that, I don't know your practice, Grant. I'm sure there's things where it gets to the point where it's a nerve issue, and you might send it to a neurologist or somebody like that, because that's the next step, right?
Sure.
It's not something that's within your scope to treat, and that's the perfect way of doing it, because everybody gets treated professionally and taken care of, and stay out of litigation. Avoidance is everything. So.
Sure. And I document that too. If I want to refer to a neurologist, I mention that to the patient. Here's who I'm referring to. Like I leave a trail to show I'm trying to get this person there. And does the patient always go to the neurologist? No, but at least the notes show that's where I was trying to go and who I was trying to involve. And the team approach I was trying to take. You got to show that.
Yeah, and that's what's interesting that you said that. That's what really changed for me about after I started reviewing a lot of cases, which is why I don't know if you remember for a different reason we were talking about I never hand a patient a card to go to someplace. Here's the main reason. It's actually worked out well for the patient, but we actually call, if I was referring to you, I'll call your office while they're in my office and get them an appointment. Or if they say they don't have their schedule, I'll say my front desk person, Dee Dee, will call and make the appointment for you tomorrow once you have your calendar in front of you.
Nice.
So if they don't show, that's as far as we can go. Right.
Right.
And, back in the day, you could have, before we had all the technology, you can fax something over, a fax referral, and then you should write in your notes, fax referral to Dr. So-and-so for appointment, right? But we can't make them go there, but that record of you doing that. So what we would do is we would write in our notes, Dee Dee called up and made an appointment at, so-and-so's office. And then if we find out they didn't show, we go back to the notes and say patient no show.
Yep.
And then we follow up. And that's just a much more careful way of doing things. So,
yeah. Well, Vic, thank you for running through this. I know this isn't the most glamorous topic and makes some of us feel kind of cringy just talking about it, but it's something we got to talk about, and it's very helpful.
So it's better to talk about it before it happens than after, correct?
Exactly.
All right, buddy.
Thank you so much. Have a good rest of your day.